Great. Maybe we'll get started for the sake of time. So thanks for joining us today, everyone in person and online. We're really happy here today for our, before we get started, I just want to acknowledge the land that we're on. So Dalhousie University operates in the unceded territories of the Mi'kmaq, Wolastoqey, and Pescataqownie peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act 1982 recognizes and affirms Aboriginal and treaty rights in Canada. And I'd also like to acknowledge the contributions of African Nova Scotians for the last 400 years in Nova Scotia. And it's an honor to be on these lands, even if it's maybe not the nicest day outside. Lots of rain and snow here, but we'll make it through. So thanks for joining us. Our presenter today is Michael Ibekaku, who is a internationally educated physiotherapist and a PhD candidate in the PhD in Health program at Dalhousie University. His research focuses on physical rehabilitation for older adults living with chronic health conditions. His PhD work examines how physical activity interventions can be adapted and implemented in low-resource settings to improve outcomes for older adults living with cognitive impairment and dementia. And prior to his doctoral studies, Michael practiced as a physiotherapist in Nigeria, where he developed an interest in rehabilitation for older adults. So I'll pass it over to Michael, and you can take it away.
All right. Thank you so much. Hello, everyone. I'm so delighted to have the opportunity to present my research today. I hope that you find it interesting, and I look forward to hearing your feedback because I'm still currently writing my thesis, so I have a lot of room to accept feedback. All right, so my research, I want to first of all talk about why I am interested in this research. I started out earlier in my life as a caregiver of someone with dementia. At that point, I was not aware of what dementia was, but as I learned about dementia over the years, I began to realize that I was a caregiver for someone with this condition. And then when I started practicing as a physiotherapist, I also had the experience of working.
It looks like you might have forgotten to specify the condition.
Okay, so when I was working as a physio, I also had experience working with older adults generally, and most of them with cognitive impairment. So I had these experiences influenced how I thought about older adults, about my practice as a physiotherapist, and over time I was interested in developing or learning how to improve care for this population, and that is what led to my research and how I think about my research, how I interpret my data. And then another thing I also want to get upfront at this point is also to talk about, in my research you're going to hear a lot about physical activity, so I wanted to also make sure that we are understanding what I'm saying. But when I talk about physical activity, I know that we already know physical activity is any activity that involves the use of our musculoskeletal systems to bring about movement. And when these activities are structured, they are called exercise. So I could have talked about exercise, but based on my own experience with older adults, most of them tend to push back when you talk about exercise, especially those that have never exercised in their life. So I am kind of strategically using the word physical activity to ensure that I'm communicating appropriately to the population that I'm looking at. So just know when you hear physical activity, I'm talking about exercise and something like that. Right, so dementia, as we already know, it is a chronic condition affecting the cognitive function of older adults. It's mostly common among people that are aged 65 years and above. There are several conditions that can lead to dementia, and the most common one would be Alzheimer's disease. And then dementia is a kind of a global problem. Currently, there is an estimated 57 million people living with dementia, and the problem is that it is projected that this number is going to double and triple over time. And the major reason was that is because of aging population. People are living longer than more than ever before. So, and one of the most important risk factor for dementia is age. So, as we get older, the risk of dementia increases. So dementia is a global problem. It's affecting different regions at the same time. But Sub-Saharan African countries, which I'm going to talk about in a second, is a particular interesting region because it's considered one of the youngest population currently, but with time they're going to become also the oldest. So currently the prevalence of dementia in this region is relatively small compared to other regions, but looking forward, you are going to anticipate that there are going to be more. In fact, it is estimated that by 2050, the prevalence of dementia is going to increase by almost 300%, given the kind of demographics and dynamics in that region. And then another thing I also want to get at this early stage is to talk about physical activity, aka exercise for this population. And my study is not trying to prove that physical activity is important for people with dementia because this is an established evidence currently. There are a lot of systematic reviews showing that physical activities improves a lot of functions for people with dementia, such as mobility, function, ability to do activities of daily living, quality of life, and behavioral symptoms. So my study is not focused on trying to prove that exercise is effective. Rather, I'm trying to understand, first of all, why there is a limited research on physical activity on a particular population, which is the Sub-Saharan African population. And then based on that, we can begin to think about how to address the challenges of not having sufficient physical activity for this population. And then talking about the Sub-Saharan Africa region as a whole, this is what I'm talking about. It's mostly a range of countries, most of them in the southern part of Sub-Sahara. In this region, there are over 1.2 billion people living in that region. While this region is very diverse in terms of culture, to give you an idea, for instance, Nigeria, for instance, which is where I was coming from, has over 300 different cultures and languages, so it's very diverse. But there are still a lot of things common among them. When you talk about the socio-political realities in that region is very similar. These tend to also affect the kind of systems that you see across these countries. Let's take, for instance, the healthcare systems. There is a shortage of resources, and most of the care system is people often pay out of pocket. So these are going to affect how people access care, and so it's more of the systems that is common among them rather than the kind of culture, because they are very diverse actually. So when we talk about this region, we always talk about how can we create systems that can be adaptable across different countries in the region. So, having said that, my research is looking at how to improve physical activity for people living with dementia in Sub-Saharan African countries in general, and specifically in Nigeria. And why this is very important is that, as we are going to find out later in the presentation, that most of what we know about the effect of physical activity and how it's utilized is conducted outside of that region, and we wanted to know, first of all, how is physical activity implemented within that population, within that region, and then what are the limitations and how can we improve that. So this is a kind of a program of research that I'm looking at, and it looks like a lot. So in my PhD, I'm not going to get to the end of that. So the blue part is the part where I was looking at finishing my PhD, and then hopefully I can continue down the line, maybe sometime after that. So that means that my PhD is divided into 3 subsections. The first part will be the scoping review, which we are going to talk about in a second. and then a co-creation study, as well as developing a feasibility study to test a physical activity program that we've kind of tried to develop for that region and see how that goes. Right, so the first study is a scoping review. As we know, scoping review is a type of study that allows us to essentially scope the literature and see what has been done. And what I was looking to do here is to, first of all, making sure that I'm not reinventing the wheel, I'm not repeating what someone else has done. So I wanted to understand what studies has been conducted in this region with respect to physical activity in dementia care. And with that knowledge, I'm going to be able to understand, even, I'm not looking at whether these studies reported effectiveness, because, like I said, we're not looking at that because it's already an established fact. But what I wanted to know is that how are these studies conducted, and how can we adapt them in a way that it can be used in routine clinical practice, because most research, as we know, some of them ends in the desktop, so we want to be able to translate the findings from our research into routine practice. Right. So the aim of the scoping review was to identify existing interventions, existing physical activity interventions, and then assess how these interventions are adaptable. The method I used was the JBI method of scoping review. It essentially has like 5 steps. First, we'll be identifying your review questions, and then going ahead to search them across several databases. And then I searched PubMed, Scopus, Embase, and all the databases listed there, as well as a great literature like Google Scholar, and others. And this search was completed in April last year, and we've published the protocol for this study in JBI Evidence Synthesis, and the study itself was published in Dementia. So the short story there was that at the end of the day, we found only 3 studies in this region. 3 physical activity programs, and 2 of them were conducted in Nigeria and 1 in South Africa. And so in terms of the interventions themselves, all of them showed improvements in several outcomes, such as cognitive function, functional ability, and societal participation. And of course, most of them align with standard guidelines for recommended guidelines for physical activity. And when I'm talking about that, I'm looking at using the prescription principle FITS-VP, that's frequency, intensity, time, volume, and progression, to see if these programs were aligned with that. So there were no problem there. So where I was looking at essentially was how could these programs be translatable in a way that people can use them in their normal practice. Okay, so just to talk about the 3 studies in a little bit more detail. The first one was a task-oriented circuit training. So people with dementia were engaged in a circuit training. They had the study had like 6 stations. So the patients went through those stations that included strengthening exercises, balance activities, walking, endurance, and the rest of them. And then the second one was also a program of study, but it included a cognitive games. And then the third one was conducted in South Africa. Again, it was a group exercise for the population that included also a program of physical activities. So another thing that I wanted to also point out was that one of the study was conducted in an outpatient clinic, which was a kind of a tertiary hospital, and then the other 2 were conducted in residential care homes. Now, these are also the details of the study. Again, I tried to use the FITS-VP principle to organize the programs that were prescribed for the patients. So I'm not going to go into so much details here, but one thing I was also going to look at was, for instance, the duration of the studies were there. For instance, the first one had 70 minutes per session, which I was thinking maybe was that too much? And then another one was a combination of cognitive games and other activities, and the patients were engaged for over 105 minutes per session again. And then the kind of games that they were used were like mobile games in Android phones, which I thought might not be. I mean, if you use it for my generation, that might make sense. But this population, for most of their life, they didn't use this phone. So again, thinking about applicability of the research. So, but generally, this is what those studies looked like. So, having completed this, I was now looking at these studies. How can we adapt them in a way that they can be used in practice? So, when I'm talking about usability, I'm looking at something that is very simple and then also applicable to the setting, which I'm going to talk about much later. So, to be able to do this, I use an approach to research called co-creation. And if you've been paying attention, currently most research is tending towards engaging patients and caregivers and end users of research in the research process. So the approach here is to start from the people that we are going to be beneficiary of my research, which in this case will include the patients themselves, their caregivers, and the healthcare professionals that are providing care for them. So I used a particular approach that was recommended by Lisk et al. They used a framework called Prodesis to organize a kind of a workshop for this what was considered the end users. So in this workshop, we try to emphasize that we are working together as a team to solve a problem that we could see that it's common within everybody. So in this kind of case, the problem was phrased as the fact that people living with dementia are not getting sufficient physical activities. So that was how the problem was framed, and then so the objective then will be to try to see how to modify those interventions that I've shown us before to make sure that we can continue to use this on a regular basis. So the approach to, the design, there are many ways that we can design these workshops. There are a lot of participant engagement approaches in research, but I particularly use the cultural adaptation. I was going to talk about that later in the slide. And then, of course, the participants were the patients, the caregivers, and healthcare professionals, which included the doctors, nurses, physiotherapists, social workers, and the rest of them. And then, of course, at the end of the day, I was going to evaluate how they felt about the process and what came out of it and the rest of them. And then we'll also think about how to make sure that whatever we agreed as a group can be translatable in practice. So for this part of the study, it was conducted in a geriatric center in Ibadan, Nigeria. Now, when I talk about geriatric center, it's a unit of a larger tertiary health institution. So it's nested within a bigger institution, and their goal is to provide specialized care for older adults with chronic conditions, including dementia. And it's an acute care, so people attend clinic there, and that is essentially the dominant care system in Nigeria and most Sub-Sahara African countries. So, for instance, people with dementia, we know that at some points during the condition, they tend to require more care. Sometimes they might require 24-hour services, but because of lack of institutional care system, so most of the care happens in their home. So, and there are no home care system. So essentially the families and the caregivers has to figure out how to provide care for them, like an ongoing care. But they often attend care centers like this maybe once a week or once in a month, depending on their healthcare system. But most of the ongoing day-to-day care happens at people's homes. And again, like I said, I had the healthcare professionals and the patients and caregivers. So I divided them into two groups. In one group, I had the healthcare professionals themselves, and then in the other group, I had the caregivers and the patients. Why I did that was that I was going to separate them in to prevent maybe the problem of power dynamics. I wasn't sure if people were going to be comfortable sharing their opinion where their doctors and nurses are there. And so for each group, I had for the patients I recruited them as dyad. So I had for each person with dementia, they had their caregivers, and then of course, so I ended up having 6 patients with their 6 caregivers, making them 12. And then for the healthcare professionals, I had three persons from each professional group that I included. So so the major inclusion criteria was their lived experience. So that's the definition of that depends on the group. For instance, the healthcare professionals, you have to have an experience with managing people with dementia. And then for each group, we had a total of 5 sessions with them. So for instance, for the healthcare providers, those 5 sessions happened over a period of 2 weeks, and then for the caregivers, it happened over a period of 1 week. It was based on their availability and all that. So for each day, each discussion day, so we had kind of a program of engagement. Again, this was adapted from the Lisk et al. Again. So on the first day was essentially to introduce to them the idea of the research, what we're trying to achieve. And so that means that we introduce them to what research is, what co-creation is, and what they were expected to do as study participants. And then in terms of to make sure that everybody understands the idea of research and also to be able to engage effectively, I also conducted or had a kind of presentation on what physical activity is, how it's effective, and how it can be used for people with dementia. So that enabled everybody to understand at least the scientific aspect of the physical activity, so that they can be able to now think about maybe ways that we can implement it in practice. So again, and then on the third day, we talked about their experiences, how they currently implement physical activity in their care setting, and if there are any maybe like on the fourth day, on the facilitators and barriers to implementing physical activity in their setting. And then on the final day, I presented to them a range of physical activity programs that has been reported elsewhere, including the 3 that was in my scoping review. So and that day people talked about what could work in each of those interventions. So the plan was not to compare each of them, rather it was to pick out what is good in each of them and try to see maybe things that we can learn from each of them to eventually form something that could work. So this is again a summary of the participants. I've talked about that earlier. So using a reflexive thematic analysis, I try to make sense of the information that was gathered across the workshops. So in the first theme, what I mentioned was that physical activity was valid but underutilized. What was clear from those conversations was that everyone understood the importance of physical activity. So it was the problem was essentially not people not knowing that this is important. It's just about having a lot of limitations that prevent them from actually translating knowledge into practice. And in terms of Team 2, what I was looking at here was some of the factors that were actually limiting people from using physical activity in their practice. So some of the factors that we have mentioned was that so first one usually happens that the people living with dementia and their caregiver comes to the clinic and they will assess for their medical needs. If they have any health complications, that gets sorted out and they go home. And next time they come again is again to assess their medical needs. So there was little or no opportunity to assess their physical needs. Again, so it's more like medicalizing their need. So if you don't have a medical need, that's it. So that was essential part of the problem. And then also another common theme that was emerging from that was becoming obvious throughout the conversation was the fact that because people already understood that people need to move, physical activity is very important. So what usually happens is that when the patients come to clinic, they are told by their doctors or physios that when you reach home, you do this activity, you do that. So because they have very little time to spend with the patient, so they tend to encourage them to do activities in the home. So if you have your caregiver takes the responsibility of making sure that you get the needed physical activity. And that's what I was trying to talk about in Team 3. So the caregivers also mentioned a range of activities they tend to do, maybe taking people to work or maybe playing games with them, whatever they felt was needed to get them to do an activity. So again, another limiting factor again was the fact that there were several structural limitations within the system. For instance, there was a shortage of staff, which is a commonly reported factor in care for older adults. So there was a shortage of staff, there was a shortage of facilities, and it was interesting because in the process, even though it wasn't part of what I was looking at, and at that center they tried to try a model of care, like they tried to have a kind of a residential care system. So they had these structures that was built to have people come in and live in there. But they quickly realized that that was not sustainable again because people pay for care out of pocket, and if you are going to receive continuous care, the costs will quickly escalate. So at some point, that could not continue. So again, it's part of the problem, the structure and all that. So now thinking about all this, I was thinking, how can we develop a care system that recognizes the existence of these limitations and then still ensures that people get the physical activity that they need. Okay, so that is where the other part of my study is coming from, cultural adaptation, which is essentially trying to modify what has been proven to be effective in a different setting to apply it in a different setting entirely to see if it can be effective. And what that entails is that because we've already identified that this doesn't work, then we'll try to modify or remove those parts that are not feasible, and then try to see how we can also apply what we've learned to make it work. So there are a range of options that we considered, and one of them was a physical activity program that was developed here. It's called Dementia Moves. Dementia Moves was a physical activity program that was developed for people living with dementia. There are many aspects of Dementia Moves, but one of the major factors that we were considering is the fact that it was a very simplified program. It essentially has just one upper body, lower body activity, and then most of the activities is on balance. And during this session here, part of the challenges that people mentioned was the fact that they are worried about engaging people that are 80 plus in activity because they were worried that maybe they were going to fall. And so we are also, so when we are thinking about what to adapt, we are also looking at a program that encourages balance, because we know balance activities reduces the risk of fall. So Dementia Move has a lot of focus on balance, and the fact that also the caregivers are the ones that spend most of the time with the patient. So we wanted to also make sure that we can develop a program that can be implemented by people that are not some experts per se, right? So, but if we can give them some level of support, are they able to implement this on their own? So, these are some of the considerations that we had to put in place to think about what we can modify. So, for Dementia Moves, it was developed again for a residential care home, but based on what we're learning in the system, residential care is not really a common practice, so we wanted to have something else that could be adapted to in a different format. So we're thinking about these are some of the modifications that we looked at applying to dementia care moves. So, for instance, the staff who implements the intervention. So originally it was supposed to be implemented by a physiotherapist, a physiotherapy assistant, and two volunteers. So some of the modifications that we are considering is to have one physio who is going to be responsible for ensuring safety and the overall delivery of the program. Then you're going to have a caregiver and maybe another caregiver, for instance, because most of this thing is done at home. So for most people, they are going to have at least two persons living in the same home with the patient. So if we can take advantage of that and then have one physio that overlooks or monitors what they are doing, and then in terms of dementia moves, again, the physiotherapist is always there to monitor whatever the person is doing. Another modification here is to consider at the beginning of the program, you can have the physio at least basically go to the patient's homes, and for the first few weeks trying to make sure that they are doing the activities in the right way and in a safe way. Then over time they can take steps back and allow the caregivers to take care of the intervention. And then of course we are looking at implementing this in people's homes instead of residential care homes. And then again, Dementia Moves was originally developed to be implemented in a group setting, even though there's each participant is carrying out their individualized program, but it is done in a group setting. But here we are keeping the individualized part, but no longer in a group session, although we still have an element of a group activity, which we are going to talk about in the next slides. And Dementia Moves on its own doesn't have much equipment, but again, we're still going to also try to minimize the use of equipment, also to minimize the cost, because people are paying for it out of pocket, and because we are also trying to do a feasibility study. We are thinking about trying this for 12 weeks and then follow up the patients for 6 months and see if they're able to sustain the activity even when we scale back the level of support that is provided for them. And then most other aspects of the original intervention was maintained. So this is what it looks like in practice. So at the beginning, the physiotherapist who is going to be responsible for overlooking the intervention generally conducts a safety screening for each patient, and they're going to go to their homes to more like do an assessment of their homes and make sure that there are no major safety concerns. And then they're also going to determine their need for equipment, and then from that information they can now plan an individualized program for them. And then to keep that element of a group activity, at the beginning we can bring everybody together because they are already attending a clinic in the same place, so we can bring everybody together to give them that sense that they are part of a bigger bigger system. So everybody's going to come together, and then there will be a training. People are going to be educated on what dementia is, what physical activity is, and how to safely implement it. So there's going to be a lot of demonstrations, and people get the opportunity to ask questions during that group setting. Then after that, most of the activity happens in people's homes eventually, and then but then they're going to be in constant communication with the physiotherapist, who is going to monitor the activities over the phone. So initially, for the first week, they're going to be there in person, but once they determine that this can be carried out safely, they can now scale back, but still maintain a daily contact with the patients. And then, of course, they're also going to make sure that the caregivers learn how to effectively document what they are doing for the patients. And then, so every other thing is essentially what I've said. So at the end of the session again, we kind of bring everybody together again to debrief and provide feedback on how the program was. So in terms of specific activities, again, this just started from Dementia Moves. Most of the programs are very simple. It doesn't require a lot of technical know-how. For instance, walking, marching, push-ups. So each of those activities are very simple and can easily be implemented by non-experts. So that is the cost structure of the entire thing. So the final part of my study will be a feasibility study. At this point, I'm not going to present that in details because I'm still hashing it out. But the idea was to test what we've just modified to see how it's going to work. And then if it works, then we can now continue down the line. But the idea of a feasibility study is to test if we are going to be able to recruit people, and then if they are going to be able to stay in the program and then maintain the structure of the program that we've designed. And then also to monitor that people are not recording adverse effects like falls. And then we're also going to monitor if they're able to retain or sustain the activity when we kind of scale back the support that is provided for them. Right, so to round off, I was thinking that physical activity is what we already know is very important and effective for people living with dementia. Not necessarily to cure dementia, as we don't know how to cure dementia, at least for now. But with this study, we can be able to develop a system that people can easily adapt to their settings and then use. And then hopefully we'll be able to get to the point where this program can be easily integrated in routine practice. So that will be the end of my presentation. Thank you.
Great. So we'll open up to questions, both in person and online. So, yeah, if you have any questions, let us know. Yeah, Jill, go ahead.
I'm thinking back to an experience I had in Africa a year ago. I spent some time in Rwanda, and I realized it's very different from Nigeria. But outside the capital city, people were walking all the time. I mean, to me, it was a country on the move. So walking was part of their everyday activity from the time you're like one.
Right.
You're walking on the side of the road. Is it that way in Nigeria, or are there people likely to spend more time in cars?
Right.
Can you just repeat the question?
Okay, so
Yeah, sorry.
okay, so she was first of all, she talked about the experience she had in Rwanda, where she said outside of the major city, people tend to walk a lot. So if she's wondering if the same is the same experience in Nigeria, yeah, I would say yes for the most part, because most people use public transportation, so you have to walk to go to where to use a public transport, and so yeah, most people do walk to be able to carry out the activities of daily living. Yeah,
I'm just thinking about how it's hard for us here to get people walking because we're in our cars so much, whereas other in other places people are much more open to a walking activity. So I wanted to know whether that was the case in Nigeria.
Yes, and it's part of what the caregivers were mentioning, that the activities they do is to take the patients to the community, to the shop, just take them around the environment. Yeah. Thank you.
Michael, thanks for the talk. Can you, I think it was on the slide you talked about the dementia moves paper, and I have to notice moderate severe dementia, but I didn't hear you differentiate. So you described dementia as just this thing. That's what I heard.
Yes.
So are people differentiate? Does it matter how severe the dementia is as far as this engagement? Have people looked at that as far as how engaged they are with physical activity? Can you describe?
Right. So, yeah, and that's part of the challenge people have with caring for people with dementia. And if you are very familiar with physical activity interventions, and they tend to, part of the exclusion criteria is always cognitive impairment, because it's very challenging to engage people that has a cognitive impairment in activity. And for each person, their limitations is going to be different. So, and one good thing about dementia moves is that it is individualized. It's highly personalized, so you can always customize the activity to people's physical level of functioning. For instance, walking can be modified for someone that is on wheelchair. Right. So for someone that is maybe is not able to, they have limitations in their upper limb, you can also modify the activity. So the emphasis again is to create something that can easily be customized to individual people's abilities. Yes. I don't know if that answers.
No, thanks for that. There's probably a spectrum.
Yeah,
right? So whenever you hear just that it's one condition, you know that it's going to have to be.
Yeah, dementia itself is not a particular condition. It's caused by many conditions. So it's very, very different across individuals.
Yes. Thank you for your presentation. I actually grew up in the United States.
Oh, okay.
And I'm
So you know.
Okay. So, was this done in collaboration with UCH?
Yes.
Okay. And I'm wondering if in the program for physical activity, if there was any collaboration with nutritionists to see what people are eating. Because I'm currently volunteering with a project in Uganda.
Right.
And they're focused on looking at nutrition, but from trying to get at different traditional foods and get people to eat based on their blood type and other things, but not looking at the Western diet, but our traditional foods, and trying to let people know which one would be helpful and which ones are not. So I'm wondering if there's any collaboration between the physical focus and the nutrition focus.
Yeah. Unfortunately, no. I did not engage a nutritionist, and that was interesting because in my sessions with the patients and their caregivers, it got to the point where it seems like it was almost like a question and answer sessions. So they had a lot of questions about maybe their dentist, their nutritionist. So I was always like, okay, this is not my area of expertise. So yeah, people ask questions a lot about different aspects of their health, but I was trying to approach this problem from my vantage point as a physiotherapist, and I try to engage as much healthcare providers as possible. So I included doctors, the nurses, the social worker. I wasn't able to. I was looking for OTs, but they didn't have OTs at the center. And yeah, nutritionists I didn't consider them, unfortunately. Yeah, but I could see, based on what people were asking me, I could see that they were also very important part of the care. Yeah. Thank you.
I guess it's kind of more of like a comment, and I guess you'll comment. But I found it really interesting that because you separated out, you had the healthcare providers, and that was one group, and then you had the DIAs, and people living with dementia. And you said, and I think it's a good reason, you separated them because of
power dynamics, yes.
Because maybe the people living with dementia and the caregivers wouldn't be as able to speak their piece if the healthcare providers were there.
Right. That's my thinking.
Yeah. And I've heard this, I do a lot of co-design work as well, and I've heard the same thing too, that community members say, like, if you want community members to be fully transparent about their experiences, there can't be healthcare providers in the room. And I think I totally agree, but I also, this is just like a comment, I think it's a bit of a double-edged sword though,
Right.
because then the healthcare providers can't hear what's happening, like, and maybe how they might be negatively affecting, or maybe some really positive experiences where they're like, oh, I should do that more in my practice. And so I think it's really, like, I'm just commenting on it, I think that's really unfortunate that there's such that lack of trust that healthcare providers will be like empathetic about it and they won't get offended, and like I just think that it's really unfortunate that we're in this space where people can't be fully open with healthcare providers.
That's true, and I noticed something like that as well, because I started with the healthcare providers, and one of the problems or reasons they cited for maybe why they are not able to implement physical activity more often was that the patients and caregivers are coming from very remote areas. So even if they somehow develop the capacity to engage them, it's going to be super expensive for them to come because they are coming from very far. And then during my sessions with the patients and caregivers, I brought this up and they were like, offer it first and then let us now decide whether to. So it's kind of
they're talking about the same thing, but they're not in the same
the same
so
page.
they
Yes.
can't hear what the other's saying.
Right. Yeah. Definitely.
There's just a question online so Ellen was asking, I'm wondering about the cultural perspective of dementia. How do people typically view dementia, and is there much stigma? If there is stigma, does this impact the ability to get people into rehab programs?
I think the stigma, the way I understand it, is that people's ability to understand what is going on. So your understanding of what's going on affects how you respond to that. Like in my own instance, I was providing care for someone. I have no idea of what was going on. And I was staying with this person before they started having symptoms of dementia. And over time, I could see how they changed significantly. And I was thinking, if I know what I know now, I could be more empathetic. Not like I was rude to them, but I could be more understanding. I could be more patient with them. And also, because depending on the stage of the dementia, they tend to require ongoing, continuous care. And but people have their lives, so what they tend to do is sometimes to lock them up in the house and go about what they need to do and then come back. So I don't think it's intentionally trying to harm them. And then also there are some parts. Some people mentioned it in my study was that because they don't know what was going on, you see some people separating the grandchildren from their grandparents. So they don't want them to go close because maybe they believe that whatever is happening has a spiritual connotation. So they don't want whatever is it to affect their children. So you see that they are physically separating their children from. So that could be again stigma, but it's based on how people understand dementia and yeah.
Sure. In one, I think it was slide 25 you had up there. Yes, the next one, 25. Yeah, the next one along. I was trying to understand, so at the end of, this is the new model for physical activity, and I was wondering, Michael, is there a role, if you're prescribing some form of physical activity for folks, that in your next slide it talks about the different types of things, so sit to stand, walking, those types of things. do you check in after a particular intervention time to know whether you've improved those particular elements? Like, I know you have a group debrief to share experience, identify barriers, and all sort of thing, but do you know if they've improved on some of these elements of physical activity? It was a curiosity.
Yeah, that's good, and that is where this program of study comes. So, at this stage of feasibility study, the goal is not really to check if there's improvement, right? So the goal is to see if we can get people into the program and keep them to the end of the program. So what we are looking at is how many did we start with, how many of them finished, and all that. So if we're able to retain them, then we'll now get to stage 4, where you are now actively testing if what you are doing is actually improving. I don't know if that
Okay, no, that helps.
Okay, all right.
Thank
you.
Thanks.
Yeah.
Based on the online question, I'm wondering, I know it's not necessarily your expertise, but I'm just wondering in general, what can we do, or what is being done to change the understanding, or more accurately, the misunderstanding of dementia?
Yeah.
Because I know from growing up there that sometimes people would say just, you need to pray more, or you need to, and so there's sometimes well-intentioned but deep misunderstanding of what's happening to someone.
Yeah.
And as you talked about, the separation of the grandchildren from the grandparents.
Yeah.
I can also imagine like the pain that would have for the grandparents, not being allowed to see their child, or even the grandchild not being able to see grandma or grandpa, but not understanding why. And I'm just wondering about if there are any initiatives to destigmatize dementia so that it could be.
Yeah.
You know what I mean?
Yeah, I understand your question. Yeah, I think it was interesting, and it's probably one part of my study that I didn't highlight so much, because that was an interesting perspective that was introduced by the social workers that participated in the study. So, in the center, they normally do what they call health talks. So when people come to clinic, so they randomly select health topics that they discuss with the caregivers while they are waiting to see their doctors. So one of the things that they suggested, because again the awareness part came up as a discussion point, so they suggested that maybe they can also talk about dementia more, not just among the patients and caregivers, but also among the healthcare providers as well, because we always make the assumption that people know. So yes, and they also talk about engaging people in social media. I mean, using televisions and other mass media communication to get the information out. Yeah, but again, this is where bias comes in, because I didn't highlight in my study because I was like, yes, and yeah, but people actually mentioned that talking about it is one way of making sure that people get to know. Because the more people know about what is going on, the more likely that they're going to because another part of the problem too is that because you don't know what's going on, you don't often go to hospital when you need to. So you see people having dementia, like the one I took care of. There was no point where we thought maybe the cognitive impairment required them going to hospital and checking to see what was going on. So we are rather responding to the physical limitations. If they are complaining of headache, you can buy something and give. But nobody was looking at them from dementia perspective. Yeah, because I don't think we understood it at that point. Yeah.
It'd also be interesting to understand from a caregiver perspective how much of this work that they're doing with their parents with dementia based on their own kind of interpretation of the value of it, given their lived experience. So, and I also wondered, how effective you see something like an in-home physio experience with the caregivers versus a professional. Like if there's some level of word, but like consistency that maybe doesn't exist to the degree with the caregiver in comparison to a professional who's going in, whose main aim is to provide that service.
Yeah, we definitely don't have that data to talk about it, but we can definitely talk about anecdotal evidence. In Nigeria, like mostly physios, there's what we call private practice. I think people do it here as well. So some caregivers, if they have the means, they can like recruit a physio to come to attend to the caregiver. I mean, to the patient at home. Some of the participants in the study at some point had physios coming, but then again, it's very expensive to have a physio coming to your house on a regular basis for a long period of time, especially for people that have that kind of cognitive impairment, which is usually the major challenge. But in terms of comparing if that is better than caregiver, I don't think anybody have that data to talk about that. Yeah.
I'm curious what motivated / possessed you to decide to look at this.
Yeah, I mean, I kind of tried to talk about it at the beginning. I was a caregiver myself, and anytime I reflect about it, I knew how challenging it was. I was still relatively young then. I'm still young.
You're still young.
Yeah, but yes, at that point, it was very challenging. I remember there was a time that I feel like whether they were intentionally trying to make my life hard for me. So it was challenging. Then when I started practicing as a physio, I also saw it from the healthcare provider perspective. So I kind of see from both sides. So I know it's a problem that someone needs to do something about. Yeah.
All right. On that note, I think we'll wrap it up. So thanks so much, Michael, for your presentation. Thank you to everybody who joined us in person and online. Our next PT Matters is Monday, May 11th, and it'll be more students doing research in our school featured. So please join us then, and hopefully Michael will be defending his thesis in the summer, so you look to hear more. Thanks, everybody.
Thank you.